Well, thank you very much, everybody, for coming. I appreciate it. The whole point with this conversation was started in my brain. I was like, I had a couple patients that they came, and mostly from my culture, which I'm proud of, but they came, says physical, but in reality, I see them for the first time, and they have a laundry list of this hurts, that hurts. In I feel this, I feel that, which is great and wonderful. At least they're coming to the doctor. But I felt like you're not giving prevention, the preventative medicine, you're not giving this important. And now I have to deal with all those issues and push the prevention on the side till I deal with all those issues. Then I have to deal with the prevention. And because when the patient has issues, we're not going to say, oh, forget about your pain. Let me talk about your colonoscopy. That's not appropriate, right? But at the same time, I notice a pattern. If some of my patients, which I love dearly, they do not come unless they are sick. And they may put physical, but in reality, they have like this list because they don't see the doctor. If I'm sick, I'm going to see the doctor. If I'm not sick, I'm fine. Why do I need to see the doctor? So that's the whole thing started in my brain. And it's like, you know what? Why don't we have a conversation about prevention and how is preventive medicine is really the way to go? Because we want to treat, we want to prevent to prevent us from treating in the future. And that's the whole thing started in my brain. So I called Suhaila, my dear Suhaila, and I said, you know what? Let's talk to the community about prevention medicine and how is that helpful to our community. May Allah put it in our good deeds.
I mean, thank you.
Then I reached out to Linda. Linda is a beautiful physician from Algeria that she's trying to work her way here, and she's shadowing me. And I see a brilliant lady, and I was like, okay, do you want to be part of this?
Thank you for having me. Thank you for the idea and the initiative. I appreciate it. And I'm sure it's going to be helpful for everyone in here and everyone watching the video later on.
Yes, yeah. So our goal is just, and she's seeing what we're doing in family medicine. So that's what we're going to talk about. So when we talk about physical, what people think of, I'm kind of curious. When we say, oh, you need to do your physical every year, what does that mean? When we talk about physicals, they talked about labs and talked about mental health, blood pressure, and we will talk about that. So Dr. Linda will talk about labs, because labs can include all ages, or I should say most ages. Mm-hmm. Or is it only for sick people?
Yes, thank you for bringing that. So now let me ask this question for you. So tell me, is it a myth or a true thing that labs are only ordered for sick people? So let's talk a little bit about labs. So yes, you are right. It's not only ordered for sick people. Actually, even healthy people may need to do some labs, right? Why we do that, especially in the age group that probably we're referring to right now, is less than 45 years old, for example. Let's take that age range. Typically, patients are somewhat healthy, not a lot of health conditions, right? Why do they even need labs? Actually, there are what we call silent diseases where they may develop in the patient, but the patient is not symptomatic. So there is no way for us to know if the patient is sick or not unless we do the labs. And that's what the labs are for, to catch the disease before the patient has symptoms. So because if you don't do that, then unfortunately, it may be revealed by a complication, like a heart attack, like a stroke. We don't want that, right? So that's why in that age group, younger patients usually, we tend to do labs to prevent, to catch those diseases early on. So what do we have as options? So for example, for diabetes, we check the hemoglobin A1C. For cholesterol, we check all the lipid panel, triglyceride, cholesterol, total, LDL, bad cholesterol, good cholesterol, and then the blood count, kidney function, liver function. So then all those can be ordered. And then additionally, we can add on other labs depending on if they have symptoms or if they have any past medical history. So that's the age range.
Can I be the devil advocate? So, Dr. Linda, I don't have family history of diabetes. Why would you want to check A1C in my situation?
It depends on the age, but typically we do that because first, it's a public health issue, especially if patients, let's say they are obese, they are more likely to develop diabetes, especially type 2, then we need to catch that early.
Yeah. So people who are overweight, people who have obesity, that also a risk factor. So not necessarily only family history, but if sometimes I actually see someone who's thin and I tell the patient, I wish I have your BMI, honestly. But then she tells me, oh, my dad has diabetes. Then even if you are perfect BMI, but with family history, then I would go ahead and order the A1C, which is the accumulation of the sugar for the last 3 months. So thank you. So we talked about labs. Also, when we go to the doctor, especially below age, we're talking about below age 45, things that you want to catch, because how many of us, young, healthy generation, they sit and check their blood pressure? Probably none, unless, they have an idea or like something is going on. So that's another important factor. When you go to the doctor, they will check your blood pressure. This is automatic every visit. So do you know how many hypertensive patients in the US? Adult population, 50% have high blood pressure. Now, the disappointing factor, which I just learned about it today, only 25% are very well controlled. So, and that too, many factors, okay? One of them, they're changing the guidelines. Now they are more strict about guidelines. The other thing is like, we don't follow up. I was like, that's normal for me. Do you know how many times I hear that, including my own family? It's like, my blood pressure is 150 over 90. Oh, that's normal for me. There's nothing called normal for you. They did the studies based on, like, took a big chunk of the population, and that's when they found risk factors increase, cardiac risk factors increase. So that lead more issues. So hypertension, we talked about labs. I see, unfortunately, I see more compliance from, I would call it, I see probably more compliance in Caucasian people. I don't want to generalize, but this is just something you see. Now, keep in mind, you have risk factors, which including African American, they have higher risk. That's just the way it is. So it's not necessarily that's compliance, but they have more risk to have high blood pressure and cardiovascular disease. So that's one of the things we want to talk about. So we talked about that. Below age of 45, something is very important for ladies, which is cervical cancer screening. And a lot of people, again, it comes to our culture, because prevention, where I was raised, prevention is not a thing. You get sick, you go to the doctor. This is different here. So you don't wait to get sick. There are certain diseases that you have to catch early, because the treatment is going to be easy if you catch it early versus it spreads. So for PAPs, which we call them PAPs, which is cervical cancer screening, actually it used to be every year. So you're right. But then guidelines changed and they said, no, if you had 3 normal in the past, then you can space it out based on your age. And I don't want to go into technicality. I don't want you guys to get bored, okay? But you are right in a sense, but they changed it. They found when they followed those ladies, if you have 3 normal, you don't need to put the lady through torture every year. But if you have 3 normal, like before, okay? So we have to educate people. So we're trying.
You're supposed to go to school.
So I did it actually before, like when I was in Ohio, in a really a rural area, and I did go to school, and we talked about it, and you would not believe the response. Kids were so engaged that we ran over the time, and they want to have more questions. It was really wonderful idea. So we'll try in the future. It needs a lot of organization, and keep in mind the issue is now with all the metal detectors. I don't want to go into that, but they're very kind of cautious who goes inside the school. So that's unfortunately an obstacle. But it's a great point. Like, that's what we're trying to educate the new generation. Like, please don't wait, and please don't, I think what we missed talking about is mental health.
Mental health, yeah.
Yeah, because mental health is like all ages.
That's true, unfortunately.
So, do you think screening for depression is something you would want to do every visit to your doctor, or no, only if I'm really feeling down or depressed? So there's something called adjustment disorder, meaning what? Meaning I am having a problem and I'm not adjusting to the problem well. I am feeling stress, but my stress is coming from certain event. So that's not necessarily because if you don't have this event, you're fine, but during this event. Now, who's going to decide that? So what with actually now the guidelines, with each and every visit the patient comes, you can screen. You can screen for depression. It's a couple questions that the medical assistant asks the patient whenever in the office. Some like guidelines say once a year you can ask those questions, but you have to at least once a year to ask. What I will ask you a question, tricky one. Men, how do you think men express stress or depression? My dad, God bless his soul, whenever we used back in the days, when we see him holding a cigarette, that means steer away. Steer away. Me as a physician, I see a lot of men, when they come, it's more physical symptoms. They don't talk about it. They don't express. They don't yap like we do, ladies, right? So when they come, and this is really like, I see it every day. Like, oh, I have headache. I have stomach pain. I cannot sleep. And then when you rule out physical symptoms, like, oh, you don't have high blood pressure, you don't have this, then it's like, okay, how have you been doing recently? Oh, a lot of stress at work. Oh, I have a new baby and I'm not coping well. So men are like different in how they express. Obviously not everybody, but generally that's what I see. So that is important. Like, you come to the doctor and then screening, it will give us more information because they are not necessarily they will have to talk about it.
Yeah, that's true. Just going back to her point, I think what I don't know if I understood your question correctly, which was the difference between sadness and depression. Yes. I think what she meant is sadness is part of the symptoms of depression as a diagnosis, but it's not the only one. So being sad is on its own is not necessarily synonymous to depression.
Agree. 100%.
And also, even the word depression, I hear it a lot among the youngest population. They say, I'm depressed, but it does not necessarily, they might be, but again, it's not, it's like a misnomer. But
yeah, that's very true. I hear that a lot. And the moment I sit down, okay, so what's going on? I feel anxious. I feel depressed. So I usually tell them, please don't use those two words and tell me exactly how you feel. Exactly. It helps us more because anxiety and depression, this is actually medical diagnosis. So that's one of the things. Keep in mind, like a lot in a lot of cultures, and surprisingly, even the Caucasian culture, like they're more educated about mental health, but we shy away from this. We shy away talking about it. It's like a taboo. It is not. I always tell the patient, please, it's like you have a flu or you have like strep throat. You go to the doctor, you get like a course of antibiotics. So now your brain is having a flu. Why not treat the brain, which is the most crucial like element in our body? So let's just take the taboo away. Now, some people will say, oh, you don't have faith, that's why you're depressed. Go read Quran. 100% Quran will make you, but that doesn't mean you're taking away this person's faith just because keep in mind, some of them are neurotransmitters in the brain. So this is really not necessarily, oh, you don't have faith. Even most faithful people, most like people who are of faith, they will have issues because it's all about chemicals in the brain. So please, like if your son or daughter comes and say, hey, I feel down or I feel, yes, spirituality, very important, study-wise, not me saying that. But at the same time, we have to look deeper a little bit. Okay. The issue is that where to balance too much knowledge versus no knowledge. So that's where the culture sometimes crash, like really like. So in our culture, we keep it hush hush, and then when we came here, it's a different completely environment. Whereas like my 11 years old, and he will hate me for saying it. He was 11. I was talking to him like, oh, why don't we engage? And he's like, Mom, I'm introvert. You're extrovert. Okay. So that's why we clash. I'm like, wait a minute. You're 11 years old. Your personality even did not set yet. But I agree with you 100%. How do we treat that? That is out of my, it is. It is. I think education with talking, being open to talk about it with your family. Because if you have like this kind of barrier is gone and I can talk to my mom or my father, they do have insight. Oh, this is serious. This is not serious. But if you don't, then that's why you have a primary care. Yeah, based on studies, okay? First of all, mental health, they found 1 in 5 in the United States diagnosed with either depression, anxiety, any like sort of mental illness. That's a lot. Like 1 in 5, that's a lot. But then also they found, like, we just had this literature that 6 weeks or 8 weeks of antidepressant in mild cases, they gave the same result of meditation 2 hours a day to do a meditation. So we are getting the same result by either taking medication or doing a self-meditation. So self-meditation is, this is a whole area. I can't talk about it. Your statement has some true to it, but depends on how bad the condition. Again, study-wise, if you have moderate to severe, it's better to do both. So therapy, which basically what you said, someone to talk to, and then medication. But that's, we're talking like severe, moderate to severe. That's study-wise. Loneliness, they found, is the most common cause of mental health. At least I just, like, this is the recent, what I read. Now, keep in mind, everything is evolving, everything. So things that I'm talking about, maybe like you read another study that shows different, but that's what I read. Loneliness here is like really big. So back to your point is not completely wrong, but keep in mind you have to be open to medication. If we're trying therapy, if you're trying to engage, if you have a supportive family, but it's not working. So you have to reach to all venues. You have to seek all those venues. To be insightful about your issues, it's a big, big problem. It's also a big barrier to treatment, because if you don't have this insight and you don't trust your surrounding, your loved ones, you're not going to seek help. And even if you do it just for to sake of just shut them up, okay, let me go to the doctor, they're not going to take medication. If they don't believe in it, the inside, it's a big problem. So I wish I have like an answer, but I feel like sometimes most of them, they know, but they're in denial stage. So have them have a conversation with their doctor. If their doctor has a good relationship, and then they express, and you as a family member express to them, that they can break this barrier. It's all about relationship with your doctor. So that's what I would suggest. And keep it. Something else I always tell patients: therapy. We all need therapy. Honestly, and that's my personal opinion. It's not a study, but we all go through hard times, right? So therapy, if we have this luxury of having someone I talk to and gives me tools to help me, why not, right? Give me one of you that did not go through a stressful event in their life. We're talking about, reaction, people are different. Don't you agree?
Yeah.
Like my reaction to certain things is way different than your reaction, than the younger generation. So it depends when it becomes like an illness. That's why we have the DSM-5 criteria, which is really, you put like things in like a numeric perspective. So just by reacting differently, like for example, 20 years old, she likes to finish her college and she wants to get a career. Another 20 years old, she likes art and she wants to go and experience art. Is that mental illness? No, that's personality. Like that's, people react differently. Primary care, like I'm a primary care, but I do have experience in mental illness. Why? Because I worked in an area that we don't have a lot of psychiatrists. We don't have this luxury. Now in Virginia, I love Virginians. Everyone comes behind him like an army of specialists. Like I see endocrinologists, I see psychiatrists. So primary care not necessarily always have they do have like certain knowledge, but it depends on your practice. So we like 50% what I see is part of it is mental illness. So you have to have a conversation with either primary care doctor, but if the primary care doctor says, no, this is beyond me, then you see a psychiatrist and they will give you like more in-depth evaluation.
I can give you an example. So for example, if you take OCD, obsessive compulsive disorder, there are personality types and there is a disorder. So basically the personality type is a type of person who is very clean, like they want things really neat and they don't want disorganization. The minute it does not affect their lives, it's still just personality type. Now, the minute, for example, they go late to work, or if they clean so much their hands, they have lesions and they get eczema, then that becomes a disorder. As long as they are fine on a daily basis, they should be just the personality type.
Yeah. So, and back to your point, some of the personality, it's a personality disorder, we don't need to treat. But if it starts to be affecting their life, their progression in life, everybody around them, they feel about it, then that's different. Let me tell you something. I will get your question, and I feel like it's a very important subject, but I feel like I'm leaving the colonoscopies and all of that. We'll do. But always I tell the patient, this is my phrase always, because do you know how many times I've heard this? A lot. Would you know what my answer? Give up on therapists, don't give up on therapy. So you change your therapist till you find, because keep in mind, you're a lady of wisdom. If you get like a therapist that she's just graduate, how would you click? There's like unless this lady is like really like experienced how to deal with. To me personally, I feel age is important, sex is important. Like a younger kid in his like 13 or 14 years old boy, he's not going to feel comfortable talking to a younger lady about his feelings. It's just that it doesn't, rare cases. So I usually ask the patient, who do you feel to talk to comfortably? Would you rather a young gentleman? Would you rather an older gentleman? So finding the age, finding the sex of the therapist, and sometimes you do all of that. Now we have shortage. We need more. Unfortunately, medication is just a Band-Aid.
Exactly.
That's why we focus on, and what you said is actually, supported by studies. They did a study on an institution, like a prison institution, and they split the prisoners to healthy diet and unhealthy diet, like the usual diet, basically. And they found their behavior, the aggressiveness is actually more with the people that are eating the regular versus the healthy. So this is what you're saying is absolutely true. Medication is a Band-Aid, but we have to look, and that's where the therapy comes in. Now, I want to touch on a few things, and I know I don't want you to get bored or get carried away. So we talked about 45. We didn't touch on something important, which starts at age of 40, and again, based on risk factors, something that all ladies need to do. Look at you. You should come here. So mammograms, that is one of the things that a lot of people, like sometimes even in all cultures, they start to steer away, unfortunately. So all mammograms are painful, or that's just a myth, or true?
I know it's a myth.
No, but is it all like painful? So the answer is not, they are not painful, they're uncomfortable, and it honestly depends on the situation. So it depends on the technique, the technician. It depends also on the amount of caffeine in your body, because caffeine makes us more sensitive, especially in certain areas. So it's a myth, it's all has to be painful. Uncomfortable, yes. Now the size and all of this, I'm not gonna go into details, but please make sure. Now, I don't have a family history of breast cancer. Why should I worry about it?
If you have the age for the screening for breast cancer, then you have to do the mammography routinely.
And okay, what if I just feel myself and it's normal? What do you think?
The self breast exam is not enough, so we need imaging studies to be able to check. Even then, when we see dense tissue, then we have to add the ultrasound. But yeah, we need imaging studies.
So everybody at certain age, now I don't want to go into the criteria because again, it's changing, but mainly we're talking about, depends on which academy you're following. American Cancer Society versus American Family Physician. I don't want to bore you, but I would say at age of 40, have a discussion with your doctor with no family history. Now, if there is a family history, I would talk earlier, but with no family history at age of 40, have a conversation and see what it's a decision you're gonna both make. Would you agree that breast cancer can cause, mammogram can cause breast cancer because it's an X-ray? So based on, again, what the current studies, again, because I say things and I tell my patient, don't hold me to it, in 5 years, things will change, not me. It is very minimal amount of radiation that should not cause breast cancer. Now, the new guidelines, they changed it. If you don't have family history, then you can actually do it every 2 years. So then that also decreases your exposure, but there are other ways that you can do screening for breast cancer. I'm not talking about insurance coverage, that's a different story, but you can do, for instance, there's ABOS, which is a specialized type of ultrasound, which has no radiation. Guidelines still but this is another modality, and you can do mammograms, MRIs, but again, I'm not talking about insurance coverage, that's a different story. But till now, what I read, there is no increased risk, especially now we're doing it more sophisticated equipment and every 2 years with no family history. When you breastfeed, you should not do mammogram. That's number one. Anybody who is, and this is not me saying it, if you're breastfeeding, your breast tissue is more engorged, more glandular because you're producing milk. So you should not have the study while you're doing that, number one. Number two, the breast cancer was really the biggest. I don't want to give statistics that I'm not very 100% sure, but the reason that we are seeing decline in breast cancer because of early detection. Now, when you say, I feel I'm fine, do you know that the breast cancer, when it starts as microcalcification. We're talking less than a size of the pinhead, okay? That's how early they detect it. Do you think this less than a pin size, you can feel it? No, you cannot. You cannot, okay? Especially you cannot. No, even big lady, smaller lady, doesn't matter. The reason we're seeing good success about eradicating breast cancer in early stages, and I have so many friends and families, and I'm sure we're all, okay? Because they found it really early, they took it out, and then they needed only minimal treatment with radiation and whatever, all modal, versus if this would have spread, you will have different treatment. You will go through different issues. Now, do we have false positives? Unfortunately, all the time. But in my mind, as a person that I lost my sister for breast cancer at age 47. Would you rather leave orphans behind you, or would you rather go through a biopsy? This is my like, I'm telling you my experience as a person, not even as a physician. My friend just got diagnosed, and it was, again, we're talking a pin, the head of the pin. Within a year, she's cured, she's fine, she didn't lose any parts of her body. Versus we have someone that got into a false positive. Everything in medicine, there is no 100%, no 100%. But I would say, I'm sorry you had a bad experience. And as I said, technician makes a huge deal, huge difference. But I would at least do it every 2 years. Don't do it every year. But don't let one person with bad experience, have an effect on all your life. That's all what I can say. Now, in 45 and up, what do we have? What do we do?
Now, beyond 45 years old, things shift a little bit. So we could also still prevent if patients do not have any condition, but then if they do, then obviously here we will work on maintenance. And then, but depending on what disease they have, we have specific labs for that. It's like having a car and then you do those maintenance sessions. You cannot really change the car, but you can change some parts of the car, and you can make sure it's working properly as much as we could. And basically the same round of labs. Additionally, we can go further with the kidney function. We can go further with for example, not only labs, let's say tests, for example, diabetic patients, they all eventually will have develop complications, let's say eye issues, heart issues, kidney issues. So for each single one, they need to see an ophthalmologist, they need to have a cardiologist, they need to check their kidneys, and that's part of the maintenance. Preventing. Yeah. So ultimately, we tend to delay the onset of complications as much as we can.
Exactly.
By doing all those labs.
And also keep in mind, that's the whole point of prevention medicine, is to prevent from you going into a condition. So, I see your blood pressure is a little bit high. Why don't we work on walking more, exercise more? Because now you don't need medication, but let's work on those things. So those are that's our goal, is less medication. Most of the doctors, I would say most, okay, like if you don't need it, you don't need it. I'm not here to pump medicine, but I'm here to tell you when you need it. After age of 45, anybody used to know when do we start doing checking for colon cancer? They found like 10%. So colon cancer was the leading cause of death. And then we screened at age of 50, but then they started to see cases that are widely spread before age of 50, before we went into the screening phase. So even with no family history. So now they pushed it to 45. So now it's not anymore the golden age 50, it's 45 based on those studies. And the interesting part is, like, now colon cancer is the second leading cause of death. Anybody knows what do they call colon cancer? They call it the silent killer.
Oh,
the silent killer, because till you get symptoms, it's bad. So, like, unless you're lucky and you it caused something early stage, but usually that's most of the time when you have symptoms, it's bad. So that's why they call it the silent killer. So please, and I see that a lot in our culture. And I'm not here to scold anybody. Like, I'm proud of my culture. I have great things, but when it comes to certain things, like, I'm fine. I don't have family history of it. I'm fine. Like, you know what? If you don't want to do a colonoscopy, that's fine. Do the poop test. It's easy. Okay? Yeah. Yeah. It's the poop box. Yeah. Yeah. And is it a true or myth that if you do this test, you have to touch the stool? No. It's a myth. You don't touch anything. Yeah, you don't touch anything. So I get this question a lot.
Yeah.
I was like, does that mean I have to touch? It's like, no, you don't have to touch anything. Okay. So so we talked about that, and that is important. The only thing about the color guard is like, or the stool test, let's call it, you can get false positive. Meaning, like if you have other conditions and there's a blood in your poop, it may come positive, but not necessarily from cancer. At that point of time, you have to go through a full colonoscopy. So they are very close. Personally, if a patient asks me this question, I tell them, if your lifestyle allow you to do a colonoscopy, I would go for it, because they go, they look, if they see something, they cut and they send it for pathology. But that doesn't mean it is, you have to do it. If your life situation, let's say I have a patient, oh, I'm moving this year, I don't have time for that. Fine, buy some time, do that, but they're very close. They're getting very close. My preference is colonoscopy if you can, though it's more invasive. But that's my preference. Per guidelines, they are both approved, and there is a whole like reason behind it. Like they found, even if you have a polyp and it starts to bleed, I don't want to go to technicality, but if personally I would say, but with that in mind, keep in mind, anything invasive can lead to complications. There is nothing like comes with a clean bill. Like, rare, but there is a possibility. Now, one of the myths are true. Is colonoscopy painful?
Yeah, you're sedated anyway.
So it's neither uncomfortable. It's uncomfortable to have the prep. Yeah, but the prep, actually they changed it now from the nasty stuff that they used, like they give you a jug to drink. That is not anymore. Yeah, so now they give you like a basically Miralax. So most of them, they give you a little bit of Miralax and a little bit of Gatorade and mix, and what is it? That's the uncomfortable. But during the procedure itself, you sleep. Yeah, you just don't. Some people will say, oh, I got cleaned better than all my life. Like, okay, that works for you.
I was just gonna adding to that uncomfortableness. So basically, at the end, you would feel a little bit bloated because they inject air during the procedure. So after the procedure, you may feel bloated, and then it's a bit uncomfortable.
But if you get a clean bill, it's 10 years.
10 years, yes.
What? You don't need to worry about it for 10 years. I'll tell you something funny. I just remembered about mammograms. I have a patient, every time I ask her to do a mammogram, she's like, I'm not going to do it. And forget it, basically. Till one day I was like, come on, I had a little bit of time. It's like, tell me, why? She's like, she went to do a mammogram. She was in the device. And the ladies know what I'm talking about, right? And then there was a fire alarm. Oh, and then the technician left her there, hooked to the machine. Yes. Yeah. So I remember that. I just want to share a laugh with you. So I'm like, I swear to God, I will talk personally to the technician. She will not leave you. So yeah. So one more thing and we're done. Okay. Bone density. Yes. So bone density.
So yeah.
This is very important. 65 and up, unless you have other risk factors. And bone density is basically to check how are your bones thinning? Are they in good condition? They are thinning. What we're gonna do about it? And again, we started without any symptoms at 65. But if you have symptoms, that's different story. And the DEXA scan is also, the small radiation should not increase your risk of cancer, and it's not, you don't do this every year. So this is not something you do every year. If you are like thin bone, like osteoporosis, you're gonna get fracture from like simple things. But no pain? No pain. It's not, unfortunately, the only time we find it like, oh, and when I say simple, like, oh, I tripped over a cord, and that we hear a lot from older ladies, right? She tripped over a cord or over her cat, and then she fractured her Why? Because she has thin bones. So not necessarily symptoms. Now, sometimes what happens, like patient has back pain, they go and they have x-ray and they tell them, oh, by the way, we see thin bones. That's not necessarily causing pain, but that's an incidental finding. Oh, I see like your bones are like, usually we see them, the bones in the x-ray shows like a really white, versus in a person with osteoporosis, or you see them like kind of translucent. Osteoarthritis most common cause is the wear and tear. Rarely I see like, oh, because you have like, you know, one of the areas that now is because of the implant of teeth, the dentist may say, oh, like, yes, the bone, like I'm putting bone and your bone crumbles. I've been hearing that since the implants, the teeth implant is starting to be. Anything like family history makes a difference, medication you're taking, and then menopause age. So those are like different, but other than that, like usually the cutoff is like, that's when we start without symptoms is 65. The diagnosis criteria is like minus 2.5. If you're minus 2.5, then you're osteoporotic. Anything below that, meaning if you're +1 or you're -1, you are now in the what we call osteopenia. Penia means like thinning of the bone. You're not quite there, but that's a thinning. But the cutoff is minus 2.5. Now, with that being said, there is another criteria. I don't want to go technical. It's called FRAX, and that's different. So sometimes people, like I've seen some physicians, and including myself, like we go a little bit more aggressive with treatment because we're seeing a decline. Those are other factors. But the cutoff, the number, if you're talking number, is minus 2.5. Oh, yeah. Please enjoy the cookies and
Can we take a picture first?
of course, please.
Yeah. Thank you.